Good morning for those on the West Coast and good afternoon to those on the East Coast. My name is Ralph Brindis. I'm chair of the CTAF panel and I want to welcome all of you today for our discussion on imetelstat for anemia and myelodysplastic syndrome, its effectiveness and value. At the beginning of every CTAF meeting, we want to ensure that all speakers disclose any financial relationships with industry. Every member of our CTAF panel who is present today has met the ICER conflict of interest policy. This time, I'm going to ask each of our CTAF members to introduce themselves, briefly describe their work, and note whether they have any updates to this declaration. So with that in mind, Dr. Rita Redberg. Rita? Moving on, Mr. Robert Collier.
Hi, I'm a longtime patient advocate and I have no updates to any conflicts at all.
Thank you, Bob. Dr. Paul Heidenreich.
Oh, Paul Heidenreich, I'm a cardiologist and health services researcher at Stanford, and I have no updates.
Dr. Annette Langer-Gould.
Hi, I'm a neurologist and epidemiologist at Kaiser Permanente, Southern California, and I have no updates.
Dr. Joy Melnikow.
Thanks. I'm a family physician and health services researcher at UC Davis, and I have no updates.
Thank you. Dr. Kavita Nar.
Hi, I'm the newest CTAF member, and I'm a professor of neurology and outcomes researcher at the University of Colorado Anschutz Medical Campus, and I have no updates to my disclosures.
Welcome, Kavita. Mr. Tony Sowery.
Hi, I represent the National Patient Advocacy Foundation and I have no updates.
Dr. Felicia Cohn.
Dr. Felicia Cohn, bioethicist, bioethics director for Kaiser Permanente in Orange County. No updates.
Dr. Rena Fox.
Hi, I'm a general internist and a professor of medicine at UCSF, and I have no updates.
Dr. Jeffrey Hawk.
Good morning. My name is Jeffrey Hotch. I'm a professor of health economics at the University of California at Davis, and I have no updates to report.
Dr. Sei Lee.
Hello, my name is Sei Lee. I'm a geriatrician and clinical researcher at the University of California, San Francisco. No updates to my conflicts.
Dr. Lisa Murphy.
Hi, I'm a professor of medicine at UCSF and an endocrinologist based at San Francisco General. No updates.
Thank you. Dr. Ann Raldo.
Hi, everybody. My name is Ann Raldo, and I am an associate professor at UCLA, specializing in radiation oncology, and I'm also a health services researcher. I have no updates.
Ms. Joanna Smith.
Hi, I'm Joanna Smith. I'm a healthcare advocate in Berkeley, California. No updates.
Dr. Rita Redberg.
Hi, I'm a cardiologist and health services researcher at UCSF, and I have no updates.
And again, I'm Ralph Brindis. I'm a professor at UCSF, a cardiologist by training, and I have no updates. At this time, I'd also like to call on individual patient and clinical experts to introduce themselves briefly and declare any potential conflicts of interest. Joanne Dornell Powell.
Yes, correction, Joan, but that's okay. I get called all sorts.
Oh, Joan, I'm sorry.
It's okay. I'm Joan Dornell Powell. I'm a patient advocate with the disease of myelodysplastic syndrome, and I have no updates or conflicts.
Welcome.
Thank you.
Deneen Saccone.
Yes, hi, I'm Deneen Saccone, Vice President of Policy and Advocacy at Cancer Support Community, and our disclosures are here on this slide, and there are no updates to that.
Okay. Next slide, please. Dr. Timothy Graubert.
Hi, Tim Graubert. I'm Professor of Medicine at Harvard Medical School and Director of the Hematologic Malignancy Program at Mass General Hospital. No updates to the disclosures that you see here.
Dr. Andreas Klein.
Hi, Andreas Klein, a hematologist and interim chief of the Division of Hematology Oncology at Tufts Medical Center in Boston. No updates.
Welcome for all of you for being with us today. I also like to request that other speakers, including the policy roundtable participants and individuals who are going to be making public comments, announce any financial relationships with industry or other potential influences on judgment when they have their opportunity to speak. We'll also present this information publicly on slides. At this time, I have the pleasure of introducing Sarah Emond, who's the president and CEO of ICER, who's going to give us the perspective of ICER and why we're here today. Sarah?
Dr. Brindis, thank you so much. Thank you for your service as chair, and to all of the CTAF members and our participants in the meeting and everyone watching, thank you for being here. And one of the few voices you'll hear today from ICER. You'll also be hearing from Dan Ohlendorf, our Chief Scientific Officer and Director of HTA Methods and Engagement, who served as the Senior Management Lead for this review. You'll hear from Josh Carlson from the University of Washington, who served as the lead economic modeler. Many of you are familiar with Josh's great work. Jeff Tice is a common participant in our wonderful meetings, served as the evidence author for this review, and is from the UCSF Medical Center. And you'll hear from Steve Pearson a little later on, now serving as special advisor, who'll be moderating the voting questions in the policy roundtable. But when we get started with every ICER meeting, we want to make sure that we're reminding everybody about why we're here. We're here because there are important new developments happening every day for incredibly important conditions, like the one we're talking about today. And we like to center our conversation, even though we're going to get pretty nerdy about evidence and value and statistics, and thinking about that patient perspective. So this quote struck us as we went through the 8-month review for this product, as coming from the caregiver of someone living with MDS. He started needing transfusions about 6 months ago when his hemoglobin got below 7. So at first, his transfusions were every other week. We'd go 2 weeks, and then it would start falling. And he wouldn't be able to do anything. He'd have no energy. And then it became more and more often. He said, I have no quality of life. And if this is what my life is going to be, I don't want it anymore. When we have our conversations throughout today about why we're here, why we do this work, I call upon everyone to remember that these are real patients with real caregivers experiencing this disease individually. Next slide. But we are here today because we have a new treatment for this condition. And when these treatments get FDA approval, there's often celebration. There's an innovation, it's now available, but it's not answering all of the questions that we have as patients, as healthcare providers, as a medical system. We want to know about the risks and the benefits. We want to know how these treatments fit in the existing treatment armamentarium. We want to know, what does a reasonable price look like? How do we think about costs to patients, the healthcare system, and the government? And then what can we do with the information about this evidence to guide policymaking in the future that is rooted in evidence? Next slide. When we have conversations about the evidence and value of a new treatment, we do so because we acknowledge the population health impact that happens when rising healthcare costs impact all of us. And we have some stories here that are linked below that I invite everyone to take a look at, but these are real families that have struggled with the rising cost of healthcare. We've seen Sherry Foy, who was forced into bankruptcy because she had to have surgery to remove her colon. The Bucks of Arizona were turned away when they tried to get care at their doctor's office because they had outstanding medical debt, and so they ended up in the emergency room. And the wards of Chicago were forced into $80,000 of debt because their twins were born premature. And more recently, we've seen what happens on the state level when the state of Delaware, in trying to provide access to health insurance for its workers, announced a 27% increase in premiums that they said was due to outpatient medical procedures, specialty drugs, and emergency room visits. And we think about that because it's hard to keep pace with wage increases that we all need and want in the face of this economy, when more and more of the money is going towards healthcare premiums. Next slide. And so we think about the patient with MDS. We think about their family when we talk today, but we also remember the other people in our healthcare system who also need access to care in an affordable way. That is the mission of ICER, is to remember that population perspective while also being focused on the patient in the doctor's office dealing with a particular condition like MDS. Next slide. For those of you not familiar, ICER, the Institute for Clinical and Economic Review, is the nonprofit that convenes the California Technology Assessment Forum. The members of CTAF are independent of ICER and represent a diverse perspective, whether health economics, clinical epidemiology, patient advocacy, or consumer advocacy. Those perspectives are important as we deliberate today on the evidence in front of us. But the work is produced by ICER and its consultants, and those are who you'll be hearing from today when we present our clinical evidence and our economic evidence. Next slide. We think it's very important, as you might have guessed, by our commitment to disclosing financial disclosures at the very beginning of every meeting for individuals participating. This is ICER's financial disclosure document. You can see a list of every organization that has given any money to ICER over the last 12 years. That's linked below. But we'd like to give transparency on how we take our funding and how we use it. Any money that is taken from manufacturers or and health plans and provider groups represented in the green bars is firewalled off, not to support any of our research, so that we can ensure the research is supported by nonprofit foundations that give us grants, as well as individual philanthropy that we receive from donors. Next slide. When you're following along at home, feel free to go find the evidence report on our website, and you can see the different sections of our report represented. But when we think about how we do this work, I mentioned earlier, it takes 8.5 months, and that's because we do a thorough stakeholder engagement process as part of every review. When we start with scoping, we talk to patients and their families, clinical experts, the manufacturer. We do our evidence synthesis, and this was led by Dr. Jeff Tice at the University of California, San Francisco, and we do our cost effectiveness modeling led by Josh Carlson at the University of Washington. We then produce a draft report where we take public comment and then respond to that public comment and update the report. We also rely on the expert review. Those are listed here, those people who gave us their perspective during the draft report creation. And please note that ICER is fully responsible for the results and the conclusions of this report, nor our expert reviewers are not responsible, nor don't assume that they endorse any part of it. Their perspective was incorporated as we finalized the report, but this is the work of ICER alone and our collaborators at UCSF and University of Washington. The evidence report is what's available. You can take a look at that on our website, and it's structured in order to support the conversation and the deliberation today. There'll be a background section. There'll be a section on patient and caregivers and their lived experience. We'll talk about the comparative clinical effectiveness and the long-term cost effectiveness. There's also a section on benefits beyond health and special ethical priorities, as well as a conversation about what a fair price would represent for this drug, and a potential budget impact analysis. And that can all be found online. Next slide. We're going to talk about value a lot today. And so this is just a picture in your mind that you can have as you think about the different dimensions of value that you will hear discussed. The dimensions in green tend to be the things that are a little easier to measure. right? Patient with a particular condition might want to know if a new drug is going to help them live longer, if it's a life-limiting condition. They might want to know if they're going to be able to have fewer side effects or an easier way of doing their activities of daily living and improvement in their quality of life. We'll also talk about the cost associated with delivering a new medicine, but also the cost offsets that might come from some of the benefits that medicine may bring. And that is the part in green that represents the cost effectiveness analysis. But we know there are many things that are important to a conversation of value that are tough to capture in a cost effectiveness analysis. And those are the aspects in blue. We'll talk about special ethical and social priorities and benefits beyond health as part of our deliberation to signal to policymakers the ways that they should be thinking about the evidence base in the context of these important considerations when they're thinking about price and access. Next slide. You've made it through the meeting convening and the opening remarks. And so it's time next we'll go to Jeff Tice to talk about the clinical evidence. Then we'll hear from Josh Carlson about the economic model. We'll take time to hear from the public on their comments and their perspectives, and we'll have a discussion. After a lunch break, the CTAF will come back and deliberate and vote on questions of comparative clinical effectiveness and long-term value. And then we'll take another break and come back for a policy roundtable discussion led by Steve Pearson, special advisor, who will talk about the policy implications and where we go from here, given the evidence we have on the effectiveness and value of imetelstat. We'll close with some reflections for CTAF and should be adjourning around 3 p.m. Pacific time today. And with that, it is my honor to introduce Dr. Jeff Tice, who will be taking us through the clinical evidence presentation. Over to you, Jeff.
Great. Thanks so much, Sarah. And so I just wanted to focus us again. We're really talking about alleviating anemia in patients living with MDS. That's the focus of, or the real benefit, potential benefit of imetelstat. Next slide, please. I want to acknowledge my collaborators. They were Shahryar Fahim and Belen Hagiwara. They're staff members at ICER, and they did the majority of the hard work pulling the evidence together and synthesizing it. My only financial disclosure is that there's a contract between ICER and UCSF to produce these reports, and I get salary support through that. I have no other conflicts of interest, nor do my two key collaborators in the evidence section. Next slide, please. So we're here to talk about the myelodysplastic syndromes, or MDS, a bone marrow disorder that leads to low circulating blood cells, all types, low platelets, low white cells, but particularly low red cells or anemia. There's also an important risk for developing leukemia, specifically acute myeloid leukemia or AML. And there's some uncertainty in the prevalence of MDS in the population, but estimates range from 60,000 up to 170,000 in the US. And the direct medical costs are quite high, up to $220,000 annually to care for these patients. Next slide, please. The diagnosis generally involves bone marrow biopsy and molecular genetic testing. The testing is important for prognosis. There are updates to the prognosis scoring system, the IPSS, or International Prognostic Scoring System, evolves as we understand these diseases, a set of diseases better, and their risk from the IPSS represents their risk for progression to acute leukemia. Next slide, please. So in talking to patients, we heard a lot about anemia with its associated symptoms of fatigue, shortness of breath. And, really, this is a major contributor to poor quality of life for these patients. The #1 complaint for patients is severe disabling fatigue, partly due to anemia and probably also just due to the disease process itself, MDS. We also heard about emotional distress due to the uncertainties about the prognosis and challenges in understanding the diagnosis. It's not something that's commonly talked about among the general population. And we heard about the financial stresses associated with the disease. One patient said of his copay requirements, "We just can't afford that." Next slide, please. So the standard of care for managing anemia and MDS initially is blood transfusions, as you heard in the patient story that Sarah told us at the beginning. However, with repeated blood transfusions, patients develop antibodies to red blood cells, and it becomes more and more difficult to find matching blood. And when you receive a red blood cell transfusion, there's a lot of iron in red blood cells, and eventually people develop iron overload. That leads to deposition of iron in the heart, in the pancreas, in the liver, leading to complications. And so at a certain point, we do provide therapy to remove iron from the body. It's an infusion of medicine. They're called chelating agents that bind the iron and allow the body to excrete it either in stool or in the urine. We also use so-called ESAs, or erythropoiesis-stimulating agents. These are hormones that tell the bone marrow to produce more red blood cells. So the goal of that is to reduce the need for blood transfusions. For certain subtypes of MDS, in particular those with a mutation called the del5q, so loss of the long arm of the 5th chromosome, there's a particular therapy that's effective called lenalidomide. And for patients with red blood cells with a particular pattern under the microscope called ring sideroblasts, luspatercept is a drug that is effective for alleviating some of the need for blood transfusions. Next slide, please. So the scope of the review, we're focusing on adults with lower risk myelodysplastic syndrome. So these are patients at lower risk for the development of AML who don't have the del5q mutation, but who are transfusion dependent, receiving best supportive care, and ineligible or refractory to the ESAs. So they no longer respond to the ESAs, and are requiring at least 2 to 4 units of red blood cells over an 8-week period. Next slide, please. Our primary intervention is imetelstat. It's the first telomerase inhibitor to be FDA approved. And it was approved on June 6th of this year. Again, here's the FDA indication from the label. And it's an IV infusion every 4 weeks based on the patient's body weight, so 7.1 milligrams per kilogram for the patient. The comparators for the primary analysis are, as in the pivotal clinical trial, with placebo or best supportive care, but we also will look at it compared to luspatercept in the population that overlaps with the indication for luspatercept. Next slide, please. Key outcomes, the FDA approved primary outcome for both drugs was transfusion independence for at least 8 weeks. That's abbreviated RBC-TI. But of course, more important is how is this impacting the patient's life? Has their quality of life improved? Are they having less fatigue? What adverse events are they having? And so we'll go through that as I present the evidence. Next slide, please. Next slide. So there are 2 clinical trials that provide evidence for this review. The IMerge trial is the phase 3 trial of imetelstat versus placebo. It was randomized in a 2-to-1 fashion, so twice as many patients received the active therapy, but it was a double-blind therapy. They were patients with lower risk MDS by the IPSS scale and were transfusion dependent. And the definition for the clinical trial was requiring at least 4 units of red blood cells over an 8-week period. And the primary outcome I already described, it was assessed at 52 weeks. For the comparison with luspatercept, we'll talk about data from the Medalist trial, very similar design, phase 3, 2-to-1 randomization, double blind. They used a slightly different, a more updated version of the IPSS revised scale, very similar patients though, and lower risk MDS by this scale. Transfusion dependence was defined as 2 or more units of red blood cells over 8 weeks, so a slight difference from the IMerge trial. So patients with a slightly lower burden were eligible for this trial, and everybody had to have the ring sideroblast phenotype. Primary outcome was the same, but it was a 24-week trial, at least for the primary outcome. Next slide, please. These are the key baseline characteristics for the two trials. You see they're fairly similar, age 71 to 72, a little more than a third female, average hemoglobin at entry, 7.6 and 7.9 grams per deciliter, respectively. Transfusion burden, as expected, a little bit lower in the Medalist trial at 5 over 8 weeks versus 6 over 8 weeks for the IMerge trial. And all of patients in the Medalist trial had ring sideroblasts, whereas only about 2/3 of patients in the IMerge trial. Next slide, please. So here are the key results from the IMerge trial. The primary outcome, highly statistically significant, p-value less than 0.001. So 40% of patients achieved at least 8 weeks without needing a red cell transfusion versus 15% in the placebo group. The duration of the transfusion independence was up to 52 weeks for those who responded to imetelstat, but only 13 weeks for those who responded to placebo. This was, again, highly statistically significant. Important quality of life measure by a scale called the FACIT, or Functional Assessment of Chronic Illness Therapy, focusing on the fatigue subscale. Half of patients in the imetelstat group had a significant improvement in this measure, and that was defined as improvement of at least 3 points for 2 consecutive cycles, to 2 consecutive 4-week cycles. 40% of patients in the placebo group also achieved this same improvement in fatigue. The publications have not reported a p-value for that. The drugs, or the study is really underpowered to look at whether the drug potentially has some impact on the long-term natural history of patients living with MDS. Progression to AML was similar in the two groups, 2% in the imetelstat group, 3% in the placebo group. And reflecting the age and comorbidity status of this population, 30% of patients in the imetelstat group died during the trial, and 25% in the placebo group. Next slide, please. For the comparison with luspatercept, ideally this would be in a ring sideroblast positive population. These outcomes are, unfortunately, we requested more data from the manufacturer, but didn't receive any more data on baseline characteristics in the IMerge trial for those, the 2/3 of patients who had a ring sideroblast phenotype. But these are results in the ring sideroblast subgroup of the IMerge trial. 45% responded or achieved the primary outcome versus 19% in the placebo group. So slightly more for both in compared to the overall results of the IMerge trial. In the Medalist trial, quite similar, 45% responded, achieved their primary outcome with luspatercept versus 16% in the placebo group. Next slide, please. So for this outcome, we did do an indirect comparison, assuming that the placebo groups were reasonably the same. You see both imetelstat and luspatercept are significantly better than placebo, with a numerically slightly higher for luspatercept, which impacts the modeling results. However, comparing imetelstat to luspatercept, there's no significant difference. The relative risk estimate was 0.9, with quite wide confidence intervals from 0.4 up to 2.3. Next slide, please. So lots of limitations to the NMA. We only had that one outcome in the RS positive subgroup. We didn't have baseline characteristics. We didn't have the fatigue scale. So we requested that, but didn't receive that. So a number of other outcomes we would have liked to have done indirect comparisons, but we didn't have the data to do it. The populations may be somewhat different. You saw that even in the overall trials, the characteristics were fairly similar, but slightly higher transfusion dependence in the imetelstat group. And so there are some issues with doing an indirect comparison when we don't have identical populations. And the confidence intervals are wide because the number of patients in these trials are relatively low. So that certainly limits the confidence in the results of the network meta-analysis or indirect comparison. Next slide, please. Key harms, there were a number of more discontinuations due to adverse events in the imetelstat group compared to placebo, so 16% versus 0%. And grade 3 and 4 adverse events were quite common. So 91% of patients in the imetelstat group had grade 3 or 4 adverse events versus 48% in the placebo group. Most of these were hematologic, so low neutrophil counts, 68% versus 3%, low platelet counts, thrombocytopenia, 62% versus 8%. And anemia, interestingly, the condition we're trying to treat with this, so there were more grade 3 or 4 adverse events related to anemia in the imetelstat group at 19% versus 7% in the placebo group. When we do the comparison with luspatercept, you see in general the adverse events were comparable in the luspatercept group and the placebo group, so same discontinuations due to AEs, nominally a few fewer grade 3 or 4 adverse events, less neutropenia, no thrombocytopenia, and no difference in anemia. Next slide, please. So there were a number of controversies and uncertainties. This was in part highlighted by the advisory committee to the FDA. There were a lot of grade 3 and 4 adverse events, particularly neutropenia and thrombocytopenia. I should have said on the slide, this didn't translate into an excess of serious infections with the neutropenia, bleeding events with thrombocytopenia. So they were managed well in the clinical trials. When patients had them, they would reduce the dose delivered and or space out the doses over longer periods of time to limit recurrent neutropenia and thrombocytopenia. When looking at adverse events, there was actually higher incidence of fatigue in the imetelstat group, so 29% versus 22%. Though, as you saw in the data that I already presented, there was slightly more significant improvements in fatigue measured by the FACIT scale, 50% versus 40%. One of the other important uncertainties is unclear whether imetelstat will improve long-term outcomes for patients. There's hope that a telomerase inhibitor would alter the natural history of this disease and lead to fewer patients going on and developing AML, fewer people progressing and dying from the cytopenias associated with the disease. But as you saw, there's no evidence of a difference right now, but the trial was relatively small and relatively short, really underpowered to assess long-term outcomes, any changes in the natural history of MDS due to this therapy. And we have insufficient data really to confidently compare outcomes between imetelstat and luspatercept in the ring sideroblast subgroup. Next slide, please. Benefits from beyond health and special ethical priorities are really important, as Sarah pointed out, in making a value judgment. And certainly there's substantial unmet need for transfusion-dependent patients with MDS. They have a high mortality and a very poor quality of life. If long-term transfusion independence is achieved, we would expect that there would be a significant improvement, not only in the patient's quality of life, but also in the caregiver's quality of life, no longer needing to transport patients to transfusion centers to get an IV infusion of red blood cells every week or two or several times a week in the case of some patients. And more independence of the patient with a better quality of life means freeing up time for the caregiver. Next slide, please. Public comments. We didn't get a lot of public comments. Really, the primary public comment on the clinical evidence was around the lack of complete data comparing imetelstat to luspatercept in the RS-positive subgroup, and that this leads to challenges in confidently comparing the benefits and harms of these two therapies. Next slide, please. So in summary, for imetelstat for anemia compared with best supportive care in patients with lower risk MDS who don't have the del5q mutation, we feel that the evidence is promising but inconclusive. The reason is clearly a significant reduction in the need for transfusions for some patients. The primary outcome was achieved in 40% of the active treatment arm versus 15% of the placebo group. but this didn't translate into apparently a significant improvement in fatigue, so quality of life for patients. And importantly, these benefits are balanced by significantly more grade 3 and 4 adverse events, including thrombocytopenia, neutropenia, and anemia. They didn't translate into infections or bleeding at an excess rate, though that's in the context of a clinical trial. And in the real world, we do worry that this would result in hospitalizations for neutropenic fevers, for instance, and additional platelet transfusions and use of different agents to stimulate the production of neutrophils, platelets, and red blood cells. And finally, there's only one relatively small clinical trial, so the certainty of evidence is at best moderate. So the balance of the benefits and harms we thought were promising, but really inconclusive given the evidence base. Next slide, please. For the comparison with luspatercept in the subgroup with the ring sideroblast phenotype, we feel like the evidence is insufficient. There is evidence suggesting not a big difference in transfusions, looked about the same. No evidence of any difference in the improvement of quality of life or fatigue. There were clearly more grade 3 or 4 hematologic adverse events with imetelstat, but our evidence base is indirect and incomplete, so we felt that the evidence base was insufficient to really confidently judge the net health benefit of imetelstat versus luspatercept. Next slide, please. With that, I'm happy to take questions. Thanks for your attention.
Thank you very much, Jeff, for a terrific and lucid presentation on imetelstat. And at this time, I'd like to offer our CTAF members questions for Jeff. And Jeff, of course, you can call on medical experts for further comments. Lisa?
Yeah, thanks, Jeff. That was a really nice summary. So, you know, you discussed the FACIT fatigue score and how there was a slight improvement with that, but that wasn't statistically significant, correct?
They didn't report it. So I'm assuming if it was statistically significant, they likely would have reported it, but it wasn't reported in the paper.
Okay, and so along the same lines, so we have maybe an improvement, but along the same lines, we maybe have a 5% increase in mortality. With an equal amount of possibility. So, you know, it's hard to just pointing out that it's very difficult to balance those. There's just as much likelihood that there's increased mortality due to due to the drug, we don't know exactly from what, as there is an improvement in the fatigue. So just wanted to point that out.
Agree.
Dr. Redberg.
Thanks, and I'll agree with Lisa, a great presentation. Can you explain how transfusion dependent was defined?
Yeah, so
I understand it was 2 and 4, but what triggered a transfusion?
This were I didn't think well, talking to patients, it clearly varied from provider to provider and patient to patient. I think we all know. I think when certainly when patients' hemoglobin drops below 7, people transfuse, but some people have cardiovascular disease start to develop, angina as their hemoglobin gets lower than 10. So it was very patient specific, and it was driven by the providers of those patients. There weren't specific criteria set out in the clinical trial that I'm aware of.
Yeah, I didn't see it either, but that concerns me because that, we didn't see a lot in how the patients felt differently, and the main difference was in transfusions, but it's a very subjective criteria. I mean, all of the patients started out with hemoglobins over 7, so it seemed that if they were getting transfused, it seemed to be for very variable criteria. And if you're checking hemoglobins and then transfusing, that's not clearly that level of what the patient benefit is versus the transfusion burden seems highly variable and subjective to me. And I'm really thinking a lot about the end-stage renal disease experience and how, with EPO, when first entered the market, all of a sudden we were transfusing at much higher hemoglobin levels and then much lower. And well, none of it seemed to make a difference in terms of patient quality of life or how long they live. So I just find that to not be a very useful endpoint.
Yeah, we may, if some of the experts want to comment here too. I know this is an area of controversy, and I think there's some effort to develop patient-specific guidance around this. But maybe the experts want to comment on when they choose to transfuse. In the end, in this trial, at least it's double blind, so the same subjectivity applies to patients on the placebo and the active treatment group. But yes, definitely.
Right. Although they must have known when they were getting transfused. So if people were using it anyway.
Tim, do you have any comments?
I would just say I agree with Jeff that it's the decision to transfuse an MDS patient is somewhat subjective. There, institutional guidelines. I don't believe that in IMerge or Medalist it was protocol mandated. It would be hard to do that. Tell the clinicians when or when not to transfuse. For example, at our center, it's exactly as Jeff said, hemoglobin below 7 or symptoms. But the one quick follow-up point I would make is that I would be careful to conflate discussion of symptom scores, specifically fatigue, and transfusion, and encourage you to kind of look at these two endpoints separately. Reduction in transfusion burden, is meaningful to patients and caregivers, as was introduced in the beginning, in terms of fewer visits to the clinic and the costs and complications associated with transfusions.
Andreas, any other comments from your perspective?
No, I would echo that comment in particular, that reducing the burden of transfusions is right, helps both the patient and whoever's giving them the ride to the clinic, and saves them many hours in the clinic each time they would be subjected to a transfusion. I think as well, if we have a transfusion threshold being just above the transfusion threshold, going from 7 to 7.1, may mean the difference between getting a transfusion or not getting a transfusion. But I wouldn't think that a patient would particularly feel much different in terms of, or subjectively be able to tease out the difference in their degree of fatigue for such a small, for just crossing the transfusion threshold.
All right, thanks for your comment.
I'll just add, it just seems you could reduce transfusion burden by changing the threshold at which you transfuse without any other changes.
Thanks, Rita.
I'll say, Dr. Bernstein, I'd like to make one or two more comments. Just, I think what we heard from patients very much was a shared decision-making between patients and their clinicians. And my sense from talking to clinicians too is they felt that that was the right thing, but certainly patients felt like that was the right thing for them. And it varied. I'm forgetting my other comment now. I just remember also that the therapy requires people come in for an infusion. So they're coming in now twice in an 8-week period for infusions to get this therapy. So it doesn't completely remove the burden of having to come into a center where they can get an infusion.
All right, terrific discussion. Dr. Melnikow.
Yes, I have a question, and it might be to Jeff or maybe the clinical experts, I'm not sure, just about the population that's affected by MDS. I know there's a question coming up for us about equity and historically, racially, ethnically underserved populations. And I'm wondering, we know it's older people who are affected by this, but are there other characteristics of the populations affected by this that you could describe, and how that is comparable or not to our overall racial ethnic distribution in the United States?
I'll take a first stab and let the specialists contradict me if that's the case. You saw from the patient characteristics. It's generally a Medicare age population, 70s and 80s. In this trial, the mean age was around 72, 73 in the two trials, but no important race ethnicity differences in this disease that I'm aware of.
Anything to add?
Quickly, just obviously the gender differences you saw in the study, that reflects the real world. There's a male predominance of this disease, but no ethnic racial differences in incidence. Just again, quickly, in terms of, indirectly though, because of the large burden of care, the health economics, caring for these patients over many, many years, it's likely that there are inequities in care based on race, ethnicity, due to the cost and the complexity of this care.
Thanks, Tim. Dr. Lee.
I'm going to apologize up front, saying that I'm going to have two questions. So the first question is about the facet scale, and in the introduction to the evidence report, the minimal clinically meaningful difference in the facet score is given as 5. And the studies actually used 3 as over 2 consecutive time points. And so that felt a little bit, if the minimal clinically meaningful difference is known, that why a smaller difference was used as the outcome in the trials. So that's the first question. Maybe I'll stop there, and then if other people have questions, I'll bring up my second point later.
Yeah, I might punt that to the experts. Do you have any comment on that and whether the facet fatigue subscale 3 points is considered a significant, or why that was used in the trial? I'm not aware of the justification.
I'm really not an expert in that area. I would be loath to comment on that. Maybe Andreas could.
No. I would say we're not using the facet scale in clinical practice. We're not asking patients to report that at the time of their visit. So I don't have a good concept of what that difference, what a clinically significant difference for a patient is.
So thank you for pointing that out, Dr. Lee. And your next question. Sorry, we're not able to give you a more cogent response, but at least it's important for us to be aware of the sort of disconnect there. Thank you.
So the second question I had is how worried we should be about unblinding, because it feels like, again, as Dr. Redberg pointed out, if there is a level of subjectivity in terms of when the transfusion, their primary positive outcome is decrease in transfusions. And one of the things that I'm worried about is the fact that so many people are having cytopenias and adverse events. And so even if the randomization was perfect, I worry that there's going to be significant unblinding from both the clinician and patient perspective, that they will kind of figure out, oh, this person very likely got active drug or not. And then the decision to make to transfuse or not actually could be tainted by the randomization, by the unblinding, unintentional unblinding. So I guess maybe a specific question would be, many trials will actually ask patients before unblinding, or ask study members, like, which arm do you think you were in, or do we have any data to kind of inform this question of unblinding?
So we'll double check on that. I haven't seen it. The one counter argument would be all of these hematologic adverse events are also characteristics of the disease. So patients with MDS do get these. So it's different from, for instance, hormone therapy, where you get postmenopausal bleeding, where it's a real indication that you're on estrogen and not on a placebo. Here, I think but your point is well taken. There could certainly be some sense among clinicians and patients. I don't think it was really known before this clinical trial that was a concern, but I think you raise an important additional level of uncertainty to the results.
Yeah, I mean, the thing that I would point out is if you look at the harms table, I mean, the neutropenia, any grade 3 or 4 is 68% in the imetelstat group and 3% in the placebo group. So this is not happens in all MDS, and so okay, I'll stop.
No, your point is well taken.
Great discussion. Thanks, Dr. Lee. Joan, you've been very patient and waiting. I'm sure you have a bunch of comments that we're looking forward to.
I just want to tell you, you got to listen to the voice of the patient, okay? I know we have all these medical clinicians and doctors, but you got to hear our voice. And the most important thing with us is we want to have a better quality of life. Now, I've been a patient, or I should say I was diagnosed in 2014. So I've been living with this disease for a long period of time. And I've had medication from A to Z. Right now I'm on lupatocin. And I went to see my oncologist yesterday and I said, what do you think about this new drug that just came out? He said, what? And I showed him on my phone. He says, oh yeah. I said, do you think that I would be a candidate for that? And then after listening to the doctors today, I'm thinking, it's almost the same drug that I'm taking now. I mean, the side effects are basically the same. So what I just want to say is, well, at least you're giving us, this is another option for us, okay? It's another option. I take my drug 21 days, every 21 days. This is every 28 days. So I think if you give us another option, that's all we're looking for. Now, regarding fatigue, we know that's going to be with us forever. So there's no drug that's going to snap us back into having all this energy and everything like that. But we know there's side effects with every drug that we get. We know the long-term effects of a drug probably will be maybe 2 to 3 years, if so. And then we're going to have to go to another drug, probably a stronger drug. But I really appreciate you listening. I know there's some other patients on this call, and I would be interested to hear what they have to say about the drug. I think it's a great option. It gives us an option that maybe we wouldn't have had years ago. But in the back of my mind, I'm thinking, this sounds like lupatocin, what I'm taking right now. So if someone could tell me what the difference is of these two, I would be happy to hear it. Thank you.
Thank you so much for your comments. Dr. Heidenreich.
Yeah, I can be quick. And primarily 2 comments. One is, was disappointed in the fatigue, and I did my own calculation. They give you the 2x2 table number, and that gives you a p-value of 0.24 for their quality of life benefit as they calculated it. And if you want the more conservative Yates correction, it's 0.30. So to me, the fatigue is roughly the same. And this, that we're doing we're doing about the same just with transfusions. And so this is a transfusion limiting drug. If it saves money on transfusion and is convenient for patients, then that's how we should be judging it. And so I agree fatigue was most important, but this is not a fatigue drug.
Did you have a question or another comment, Paul?
Nope, just wanted to provide, so people were asking about the p-value. I thought I would give that.
Okay, and that's why we love you. All right, Dr. Nair.
Joan, thank you so much for sharing, what the impact of this drug and from a patient perspective. So just related to that, to Dr. Tice and the clinical experts. So we talked about some of the other adverse events, right? Thrombocytopenia, neutropenia was substantially higher compared to the with this drug. What does the management, even though they weren't severe and required hospitalizations, they were managed by, I think, dose reduction, things like that. I was curious, what does that look like from a patient perspective? Does it require, changing the dosage? Does it require more visits? How resource intensive is that? Even though it didn't require hospitalizations, what does that look like from a clinical perspective? And what added burden does it provide or impose on the patient and caregiver?
Right. I mean, certainly, I think there's some evaluation. I think my team can correct me if I'm wrong, but I think about half of the patients, 49 patients in the imetelstat group had dose reduction because of these. So I think they're primarily managed by dose reduction, so they don't recur with the next cycle. But the actual management of neutropenia, I'm sure there must have been some isolation, careful monitoring for fevers, that sort of thing, and sometimes Neupogen or other stimulating factors given. I don't recall the exact data on that in the IMerge trial. Maybe our experts would comment on how they manage these when they're seen with any therapy in oncology or hematology. We see this not infrequently.
I'm just going to chime in if it's okay with an add-on to that. Does it require extra testing to see if there's this neutropenia right after the infusion, or how do you monitor for that? That wasn't my question though, but I just wanted to add that.
Tim or Andreas?
Maybe I'll take the easier part first. I would assume that that the neutropenia is being recorded probably at the time they come back for the next dose, and resulting in either a delay or a reduction. The reason these what do I say, the goal of treatment for these patients is helping to improve the quality of life, and so we're not looking to to increase that burden. These patients we would typically not be adding more drugs, adding on a growth factor. We'd be trying to kind of reduce the effects of the drug that we're adding rather than adding yet another drug. This isn't chemotherapy in a curative setting where we're trying to optimize the amount of treatment we can provide, also, I know that we wouldn't be doing, I wouldn't anticipate that they would be doing invasive procedures like bone marrow biopsies to try to figure out what's going on or what's changing. This would be managed more on the level of dose adjustment. Right? If somebody becomes neutropenic, you may add on an additional antibiotic, for example, as a layer of protection against infection for a period of time that their counts are low. You might bring them back more. You may bring them back in a week to reassess the count level, where perhaps if they hadn't been neutropenic, you wouldn't have. So there probably are some additional burdens in terms of care that occur when the counts are low like that.
I'll just briefly add to that. I agree with everything Andrew said, but important to point out first that most of the study participants on IMerge were ex-US, right? So there's essentially no experience directly with this drug so far in practice. Certainly, I've never given it, although we did have one patient in my group who's on the study. So our answer is really extrapolating, as Ralph set this up, from other therapies that cause cytopenias and low blood counts in this patient population. I just want to give that caveat. And I agree with those maneuvers. The one thing I would add, and I'm sure we're going to talk about these low blood counts a lot this afternoon. I believe in the publicly accessible ODAC slides that were shown during the discussion. I don't know if we can get into that. There was a slide that showed that these low blood counts were particularly a problem in the first cycle of therapy and really pretty dramatically stabilized thereafter. So it doesn't, at least from those data, it didn't look like this was an ongoing month after cycle problem. It's particularly acute in the first cycle. I just wanted to introduce that.
Thank you.
Thanks. I appreciate that our time is coming up soon, so I'm asking for quick questions and maybe quick answers. Dr. Murphy?
Yeah, I'll be really quick. First, I just wanted to thank Joan for bringing up the quality of life, the overall quality of life, not just the fatigue, and just to let her know that this is something we come up against all the time. The thing we want is improvement of quality of life for our patients, and the drug companies do not assess that in their trials. And that data is always lacking, and it's a real problem. My quick question is, Jeff, can you just remind us the durability, how long, because again, to Joan's point, how long do we know these drugs are working for? What's the duration we have so far?
Among those who responded, the median duration in the IMerge trial was 52 weeks, so about a year. So, a substantial proportion of patients do have transfusion independence for a year.
Thanks, Dr. Murphy and Jeff. Deneen, you get the last word from the patient perspective.
Thank you. So I wanted to have an opportunity to kind of underscore and weigh in on what Joan said earlier, particularly from a patient perspective and what they are looking for. So at Cancer Support Community, we actually have a cancer experience registry where we ask patients in treatment or active treatment, about quality of life and what they want in terms of quality of life outcomes through our Promise survey. And of the 150 MDS patients that participated in the survey, what is important to them? One of the comments we received back from a patient is, I know there's no cure for MDS, but what matters to me is having a wide variety of treatment options, being able to have less transfusion dependence, being able to have more energy, being able to spend more time with my loved ones, being able to eliminate some of that burden on my wife or caregiver, for example, as it relates to taking me to appointments, as it relates to chores. Just having that extra opportunity in the toolkit as part of their decision-making with their physician. That is what is important to them, a wider variety of treatment options for a condition for which they understand there is no cure.
Janine, terrific comments. Thank you so much. At this time, I'm going to move along and ask that Dr. Josh Carlson give us his presentation on the evidence and economic modeling for imetelstat. Josh?
Hello, everyone. Can you hear me all right? Sounds good. My name is Josh Carlson. I'm a professor at the University of Washington at the Choice Institute, which is a health economics and outcomes research group. Next slide. Working with me on this was Linda Liu, who did the bulk of the modeling work and a lot of the heavy lifting, as well as Marina Richardson from ICER. Our disclosures are below. We just have a contract with ICER. That is our only disclosure. Next slide. So our objective was to evaluate the lifetime cost effectiveness of imetelstat compared to luspatercept or best supportive care for the treatment of anemia in transfusion-dependent
lower risk myelodysplastic syndrome adults without the del(5q) mutation who are ineligible or refractory to erythropoiesis-stimulating agents. Next slide. We have two populations of interest here. First is the all imetelstat eligible patients, and the primary comparator here is best supportive care. We also have the population that's focusing on the ring sideroblast patients, and the primary comparator here is this person. Next slide.
Josh, sorry, just to let you know your audio is a little off.
Yeah, just move closer to the
here is our methods overview. We have a Markov model.
Josh, I am having a lot of difficulty hearing you.
United States setting, it's a healthcare perspective and a modified societal perspective.
Yeah.
We are looking at a lifetime time horizon, discount rate of 3%, cycle length is 4%. Sorry, cycle length.
Josh, can you hear us?
Our primary outcomes are the cost per quality adjusted life.
I don't think he can hear us.
Value of life years gained.
Josh, can you hear us? Josh, can you hear us?
Sorry, can you?
Yeah, something really went out and you're going to have to start over because we didn't hear anything you were saying. Now we're not hearing anything at all. I'll let the technical staff take over, but I just wanted to make sure you knew there was a problem.
Can anyone hear me? Okay. Everyone can hear me?
Much better.
Now you're coming through pretty clearly. Thank you, Josh.
Let's just start again. So where do we want to start here?
Looks
Okay.
good.
All right. The objective here is to evaluate the lifetime cost effectiveness of imetelstat compared to luspatercept or best supportive care for the treatment of anemia in transfusion-dependent, lower risk myelodysplastic syndrome adults without the 5-del(q) mutation who are ineligible or refractory to erythropoiesis-stimulating agents. Next slide. We have two populations. The first is the all imetelstat eligible patients. The primary comparator here is best supportive care. Our second population is ring sideroblast patients, and the comparator here is luspatercept. Next slide. All right, we're going to go over our methods. It is a Markov model we're using. The setting is the United States. We have two perspectives. One is the healthcare sector perspective. The other is a modified societal perspective. We're using a lifetime time horizon, 3% discount rate. Our cycle length is 4 weeks, and our primary outcomes are the cost per quality adjusted life year gain and the equal value of life year gained. Next slide. Okay, so here is our model schematic. And this is the way that patients flow through the disease states of interest. Patients start in the transfusion-dependent health state. We have two health states within there. There is the low transfusion burden and high transfusion burden. And patients can transition from those transfusion-dependent health states to transfusion independence according to our response to that definition, which is greater than 8 consecutive weeks of transfusion independence. For the all patients analysis, we have independent transition probabilities from those two sub-health states of transfusion dependence. For the ring sideroblast population, we only have a single transfusion, or rather transition probability that is due to lack of data. Once patients are in the transfusion independent health state, they can transition back to transfusion dependence according to the duration of response that Jeff just spoke to. From at any point in the model, patients can transition to high-risk MDS, acute myeloid leukemia, or death according to disease progression information. Next slide. Okay, here's the baseline characteristics. These are based on the IMerge trial. We've already seen these to some degree. And you can see we have information on the median age, distribution of female transfusion burden at the beginning of the model, as well as the IPSS distribution. Next slide. We have a few key assumptions that we'd like to detail here. The first one is that response to treatment is defined as achieving transfusion independence for 8 consecutive weeks or longer. That's based on the trial endpoints. Assumption number 2 is that responding patients transition to transfusion independent state after the first 4-week cycle. That means they spend 1 full cycle in the transfusion dependence health states before they transition. And that was based on some data that we had from the trial that informed that that's when the majority of patients do transition. Assumption number 3 is that patients do not move between high and low transfusion burden states. This is primarily a function of the fact that we did not have data to inform this transition. We did ask the manufacturers for this data, but it was not provided. Next slide. Assumption number 4, patients discontinue treatment if they have no response by 24 weeks, lose response, or progress. Assumption number 5, treatment has no direct effect on disease progression or death. Assumption number 6, the baseline characteristics, adverse event frequencies, and dose intensities are the same in the ring sideroblast subgroup as the overall population in IMerge. Again, this was due to a lack of data specifically on that subgroup. Next slide. Okay, so here are our treatment-related efficacy parameters that we use in the model. For the all patients analysis, we have the response rate in patients who are low transfusion burden at the outset and who are high transfusion burden at the outset. We have both those for imetelstat and best supportive care. The bottom row there is the median transfusion independence duration. You can see the difference between those on imetelstat and best supportive care. In the model, we actually translated these into transition probabilities using survival models. Next slide. Slightly different approach for the ring sideroblast subgroup. And that is because of the data that we had available here. We have a single estimate for the transition to transfusion independence. We have the best supportive care number, and to that we applied relative risk estimates from the indirect treatment comparison that was performed by Jeff and his colleagues. And that's how we get the response rates for those specific drugs. And then again, on the bottom row, we list the transfusion independence durations in terms of medians that were translated into transition probabilities using survival models. Next slide. Here we have the key treatment costs for imetelstat and luspatercept. The first row there for imetelstat is the net price and the net annual cost, as it would be at the sort of starting dose. The second line down includes if we are incorporating dose reductions into those estimates. The first luspatercept price includes a 9% discount. That's based on data from SSR Health. And the row below that includes up titrations that may happen in the course of treatment. So those are the different prices that we have there. Next slide. Here are key MDS-related costs. So we have costs related to being in the high-risk MDS state in the first year and the second year. We have the cost of being in the AML health state. And then we have a number of costs related to the best supportive care components of these treatments related to myeloid growth factors, red blood cell units, platelet units, and inoculation therapy. Next slide. We have MDS-related administration costs. These are just basically the costs as listed here for different administration components, and these are based on the CMS fee schedules. Next slide. Here are health state utilities. These are trying to capture that quality of life component for the different health states, and they range from a low for the AML health state of 0.53 utility up to a 0.84 for transfusion independence. I will note that there's a variety of sources here. We didn't have a single comprehensive set of health state utilities as we sometimes have to inform this, but these are all reasonable estimates and have been used in previous analyses. Next slide. Here is information on the grade 3/4 adverse events. We have the rates on the columns, the columns to the left, treatment costs per event listed there, and then we have the disutility that we apply per event. Of note, the disutility here is only expected to last 2 weeks. So going back to the comment that was made that a lot of these are are short term in their duration and are resolved through things like dose reductions. Next slide. All right, now I'm going to move on to the results. So here we have the base case results for the all patients analysis. We have information on imetelstat plus best supportive care versus best supportive care alone. You can see that the intervention costs are increased, total costs are increased, total red blood cell units transfused, there's a decrease in those of 10. Then we move on to the QALYs. There is a small increase in QALYs and a small increase in equal value of life years gained. This translates into the incremental cost effectiveness ratios that we see below, where we find that the cost per QALY gained is about 1.2 million, and the cost per EVLY gained is just over $1 million. Next slide. Now we're going to focus on the ring sideroblast population. Here we have the similar sets of information for imetelstat and luspatercept. You can see that there's an increase in the intervention cost for imetelstat, an increase in total cost for imetelstat. Red blood cell units transfused are equal. There's a very, very slight decrease in QALYs favoring luspatercept, as well as equal value of life years gained. But again, those are very small increments. So for this, we judge that imetelstat is more costly and potentially less effective, although that effectiveness, again, is very, very close. Similar conclusions for the cost per EVLYG gained. Okay, next slide. We did a variety of sensitivity analyses. The first one is called a one-way sensitivity analysis, where we're moving individual inputs into the model. The key drivers here are the utilities, some parameters related to mortality, and then a number of parameters that are related to the costs of treatment. Under none of these sort of low bars, the low end of these bars, do we approach differences in our conclusions about the cost effectiveness of these interventions, or this intervention. On the bottom, we just have pointing out that in our probabilistic sensitivity analysis, across price thresholds of 50,000, 100,000, 150, and 200,000 per QALY or EVLY gain, 0% of those iterations were cost effective. Next slide. Here we ran information. This is information from a number of scenarios that we run. We have the base case results on the left, and this is for the all patients analysis. Scenario 1 just pulls in a modified societal perspective, so pulling in some of those productivity-related issues. Very small improvement in the ICER. Scenario 2 is if we use a more conservative response definition of 16 weeks of transfusion independence. You can see it goes up a little bit. Scenario 3 is where we tried to pull in information about transitions from the high transfusion burden to the low transfusion burden using information from a partial response. And you can see that does have a slightly improvement in the ICER. And then on the last scenario, we looked at if there was no indirect impact on mortality. And again, it spikes a lot. Under none of these do we change our conclusions about the overall cost effectiveness of the intervention. Next slide. Here we have the health price benchmark information. The annual WAC price is the first column there. And then we can look at, there are ranges of the health benefit price benchmark ranging from about 95,000 to about 115,000 across different annual price thresholds and between the QALY and EVLYs gained. All of this would require substantial reductions in the current price or substantial discounts off of that WAC. Next slide. This is getting to the unmet need or the disease burden in this population. What we show here are what's called absolute shortfall. That is the decrement between the expected EVLYs for this population versus a general population. You can see there's a shortfall of about 9 equal value of life years. And then on the right, we have a proportional estimate of that relationship. That's about 75% of a shortfall there. For context, we provide some of those estimates for other disease areas to kind of put this in place with those other disease areas in terms of understanding that unmet need. Importantly, what's largely driving this is the MDS component, not necessarily the anemia component of this. But this is for all of the patients. It's not really related to the treatments themselves. It's just a measure of the unmet need or burden in this patient population. Next slide. Some limitations, we did have limitations related to the publicly available data. We were unable to inform transitions between the high and low transfusion burden health states. We also had to assume that the ring sideroblast subgroup in terms of adverse events, dose reductions, and baseline characteristics were equivalent to the overall population. The utility estimates from the SENZ publication were obtained from surveys that described transfusion states broadly and included a variety of health issues. So though they are, we feel relevant and have been used in previous analyses, they are not specific to these treatments or were taken from these specific patients undergoing these treatments. Next slide. We received a few comments. One was the lack of movement between high and low transfusion burden states. I spoke to that, but we did not have specific information on that. We did try and do a scenario analysis where we used partial response information, did have a small effect, but nothing that would meaningfully impact any conclusions. Some comments about the cost differences between lower risk MDS health states. We feel like the cost estimates that we did use were reasonable, and we did comment to that in our response to that. And there was a comment that we should update our placeholder cost for Imetelstat with available wholesale acquisition costs. In the transition from the draft report to the final report, there was a price that was made available, and that is what we use in our final analysis. Next slide. So by way of conclusion, Imetelstat provides small gains in QALYs and EVLYs relative to best supportive care, also reductions in transfusion units transfused, or sorry, red blood cell units transfused throughout the patient's lifetime. At the current wholesale acquisition cost of Imetelstat would not meet commonly cited cost effectiveness thresholds. When compared with luspatercept in the ring sideroblast population, Imetelstat was more costly and less effective. Next slide. With that, I'll take questions and apologize for my technical glitch at the beginning.
Josh, thank you very much. And you came through admirably with your lucid presentation when you came out from under the water.
Yes.
So with that in mind, I already see some questions from our CTAF panel. Dr. Raldo.
Yes, thank you so much, Dr. Carlson, for the presentation. It was really clear and informative. I was wondering, you did mention in your limitation slide the source of the utilities. But I was wondering if you could say a few more words about the source of the utilities, what kind of health state, you alluded to some other health states, like what other health states were included, what states they actually measured, how many patients were included. Because if you look at your slide for the source of utilities, there is a bigger delta between kind of the low and high burden than there is between the low burden and the transfusion independence, which I thought was interesting.
Yes, so I'm not going to be able to pull off all those numbers off the top of my head. We can sort of dive into that study and perhaps comment in a little bit. Maybe Linda, if you want to just prepare to, that's my colleague, prepare to comment specifically on that study. I will note, and I try to note this, that when you have a variety of sources that are from different sets, sometimes you get little illogical differences. We don't feel like these are illogical, but if you had one comprehensive set for example, from the manufacturer for patients actually in these health states, it tends to align a little bit better. We did ask for that, didn't have it. So these were essentially what was the best information we did have available. When I spoke to the sort of being transfusion independence more generally, it was that it was not necessarily in this low risk population only, and these sort of more specific populations that we're trying to model. But it was relatively close to this population. And so, for example, some of these estimates were used when CTAF did their review of luspatercept originally. So they were sort of deemed sufficient, but it's not necessarily what we would have as a gold standard or our preferred set of utility values. In terms of logical consistency, yes, there are some bigger jumps. The jumps between low and high, again, there's a distribution there. And so what the actual mean value is a little bit tricky in terms of understanding. It's sort of a range, but you don't know where exactly they fall. There is a jump, though, when you get to transfusion independence. That's the highest state. Clearly, that's where patients want to spend their time. And that would theoretically capture both sort of the quality of life as in terms of function and feel, but also perhaps not having to go in and some of that burden that you might also expect to experience having to have those transfusions. So it is hopefully capturing those elements.
Thanks. Rita?
Thanks, Josh, for the interesting analysis. Perhaps I missed this, but my understanding was we did not see a quality of life benefit, and if anything, deaths were higher in Imelstat group. So I'm not clear on how you calculated a quality improvement compared to best supportive care.
Sure. So we don't see an improvement in there's not a quality of life overall measure. It was, I believe, related to fatigue primarily, which is one of the major components.
But not a significant difference, yeah.
Correct. Now, the statistical significance is more on the clinical parameters. If we see numerical differences, those do get pulled over into the way we do our estimates. And then, the uncertainty analysis does capture some of that. So again, not having the specific link between the patients who were transfusion independent in this trial and their utility scores gives you a separation between what we're pulling in a utility score for transfusion independence more generally in a population like this. So we can't quite get that one-to-one with how the quality of life impact would have been experienced by these exact patients. Rather, it's by patients in general who have experienced transfusion independence, who had a transfusion burden ahead of time. So that is a limitation in the way that the quality of life component is actually captured here. In terms of mortality, that mortality component, it was not, it's a shorter trial. It's not we used information from the population more generally in terms of the mortality impacts. There are not large mortality impacts at all here. So the increment is really being driven by that slight benefit for the patients that did achieve transfusion independence in a relatively higher rate than the best supportive care group in that population.
So the data was not actually coming from the trial for either quality of life or mortality, one could say.
That is correct. Correct. Yes. The mortality component was yes, that's right.
Thanks, Josh. Tony.
Yeah, I have a question for Dr. Carlson. Does the cost for the Myelodysplastic of $365,000 a year, I think it is this just the cost of the drug, or does that include all of the delivery costs and the doctor's office costs?
That is just the drug cost. If it's when it's termed the wholesale acquisition cost or the WAC, that is just the drug cost.
Okay, thank you.
Now, not all patients obviously are on it the full year. That's sort of a thing. That's what the model is trying to capture, is the fact that not everybody responds, and when people don't respond, they come off drug. If they lose response, they come off drug, something like that. But if someone was on it the full year, that's what that sort of list price would be for them.
Thank you.
Jeff?
Thank you. Thanks again as well for your presentation. The last bullet in your conclusions says, I think, that drug I is more expensive and less effective than drug L. And I just want to make sure I'm understanding that that's what you're saying, looking at the estimates, like the quality of life number is bigger for for drug L than it is for drug I, but it's not really like we've done a statistical test and said this isn't happening by chance. It's sort of like saying, this is what I see when I look at the estimate without checking on whether this could be happening by chance.
That is right. Our point estimate is that showing that imetelstat is slightly less effective in terms of qualities and EVL wise. Very close. I mean, as you know, you're familiar with the parlance. This could easily be moved to just a cost minimization type of analysis, which they're very, very close to each other. You know, the uncertainty component of this would reveal that there's a lot of overlapping, right? But the point estimate is slightly lower, so we put it in that category. But to your point, they're very close, and they could be considered essentially equivalent. The red blood cell units transfused, no difference there, right? Key component here. So you could think about this as just almost a pure cost minimization type of analysis.
Would I be wrong to think about it the same way for the cost? I think what you're telling me is the outcome's about the same with either drug. I know it's not exactly what you said, but that's how we say no different. If I'm looking at the costs and I'm looking at the two drugs, am I okay to say we don't really find a difference, or is there like a big enough difference to write home about on the difference in the costs?
So I'll just speak to my opinion here. I think that there's, you know, the delta on the cost is certainly more substantial in terms of what we see. The imetelstat cost is, there's no there's no discounts already included in that luspatercept. The value we're using, it does include a 9% discount already. So it will be ultimately a function of what the pricing, where the pricing lands. This is sort of a little bit cart before the horse, because this is trying to inform that pricing, and we'll see how that part works. But in my opinion, I think that the delta around costs is something that's more, you know, substantial, or that you would put more weight in. That there is likely a difference there, according to our current estimates, relative to the clinical side, which we see is very, very close between those two.
Thank you.
Dr. Lee.
Yeah, this might be a question. So again, thanks, Josh. I felt that was really, really super clear and very helpful. This may be a question that straddles the modeling or versus the evidence. I was wondering if we knew about the distribution of response and how the modeling may have accounted for that. Like, for example, the clinical experts talked about how, you know, the adverse effects really seem to happen up front. Are those the people that we know are generally going to respond favorably, have a favorable response? And so can we you know, stop treatment if people aren't responding within a week or two? I guess, you know, the deeper question is, when we see this kind of, you know, 40% who have transfusion independence, does that mean everyone gets some benefit and some people just get more, or are the people not benefiting just not getting any benefit, and so they can be they don't need to be they only need to be treated for a very short time?
Yeah, good questions there. So I'll let the clinical team speak a little bit to whether there were groups that responded differentially or not. We didn't have that, for example, by the adverse event component. I will say that a large proportion of patients who did responded around that 4-week period. So you do see a real big component that moved when they did. Now, there were responses that happened later. So in our model, we put it there because the bulk happens there and you have to make some choices when you're modeling. But there were responses that happened later. There is a chart that actually kind of shows the timing of all of that. May be worth pulling up if the clinical team has it available. But there will be a question about how long you keep people on therapy and wait for that response, right? In our model, we put that at, I believe, 24 weeks. Which was sort of giving them sufficient time to respond. If you're going to respond, hopefully respond by that time, and then we'll pull it off. But there is a clinical judgment piece, and I'm sure in actual practice it will vary a little bit, but how long people want to wait for that. So perhaps the clinical experts might be able to speak to that as well.
Jeff, did you want to comment on that, or I had some
well, I was going to make another related comment. I'm going to this is addressing the adverse events and dose reductions over time. for neutropenia, for grade 3 or 4 neutropenia, it happened in 36% of patients during cycles 1 through 3, cycles 4 through 6, 13%, 7 through 12, 13%, 13 and plus, 13 and higher cycles, so a year out, 15%. So there was a drop, but there remains substantial grade 3, 4 neutropenia. I'm just pulling up the neutropenia, and there were ongoing dose reductions and need for amyloid stimulating factors, out for many cycles. In terms of whether there was any different, any patient characteristics that predicted response, I don't believe so, other than the degree of transfusion dependence initially. Clearly, people who only were getting a couple of units every 8 weeks were more likely to respond than those who were requiring 8 units over the first 8 weeks. As far as I know, there are no other predictors of response to imetelstat.
Tim or Andreas, any comments on this issue?
Well, maybe in response to the specific question, again, with the caveat that I was speaking generically about, having, lacking specific experience with the imetelstat. Yes, it is a judgment call, a discussion between the patient and the provider about how long to wait and continue therapy until, you decide that it's working or not working. It's definitely not on the order of, a week or two. And I think it would be several months in this case, assuming that there isn't toxicity.
Thanks, Tim. Before I get to Dan, Lisa was wondering if how many patients were there frank discontinuation of the drug for adverse effects? I don't know, Jeff, do you remember that?
It was in the slide set. We can look at it. I believe it's 16%, but I'd have to go back and double check. It's about 16%, give or take. All
right, thanks. Dan, thanks for your waiting. What's up?
Sure. I just wanted to provide a little more context around the two questions that Jeff Hotch asked. So when you're talking about the comparison of imetelstat and luspatercept, I think the difference, and Josh, you can jump in if I'm misstating, but I think the difference in the effectiveness delta really comes from a different response rate in the placebo group of those two trials. That I think that the effectiveness in terms of transfusion independence was just about the same between the two, but there's a bit more of a delta in favor of luspatercept because of a slightly lower response rate in the placebo group. In terms of cost, and I don't expect that everybody went deep into the bowels of the supplement, but there are tornado diagram sensitivity analyses that are comparing the cost of the two drugs and changes in imetelstat cost, and you can see how whether that does or does not affect the comparison. So if we were to assume some sort of a discount at about 9% for imetelstat as well, I think you'd still see higher costs in that group.
Thanks, Dan. Joe,
real quick, I think we
go
just
ahead.
have information to follow up on the utilities question. Linda, do you just want to pop on and comment on where those sources came from?
Sure. So the utilities we used for the transfusion independence and transfusion dependence states came from one source, and that was used in other cost-effective analysis before. But one of the limitations of that source is we used their values that had a mix of patients from outside of the US. So this included UK, Germany, and France. They also obtained their patients for that study from a patient organization, which may have had milder disease when compared to the overall population. The questions they asked in their survey were kind of broad. They included fatigue and tiredness, as well as like how often you experience worries about your future, and not just on transfusion dependence or transfusion burden.
Great, thank you. Yeah, so just a little bit of perhaps a more mild population in that one, and from a variety of countries as well. So again, pulling information where we had it, but with some caveats. Thanks, Linda.
Joan, how about some patient input here related to these issues of cost?
Okay, now I know the drug was approved in June of this year. So clarify for me, was this a clinical trial prior to June? Also, a lot of patients say, I'm involved in a clinical trial, let's say with this drug, but the cost, I mean, it's working for me, but I can't afford the cost. So is that a question that you ask prior to the patient dynamics, whether or not you would be able to afford the cost if it does work for you? That's just a question a lot of patients have. Sure, I'll be in the clinical trial, but once it's finished, I don't know if I'm going to be able to afford the cost. Has anyone did any statistics on that? And how long is the drug being used now here in the United States? Are patients starting to use that drug? Is it available? That's my question.
Yeah, great questions. We've only heard anecdotally about the cost concerns, given that it's so new, so uncertain in that regard. The trial was conducted a couple years ago, and so that would have been prior to this. And I'm not sure if anyone else has information on the patient cost. I know that just anecdotally we heard that there were certainly concerns, and there are often concerns with that when the annual price is so high like that we do hear those concerns.
Thanks, Joan.
Sorry, I'm just going to jump in, Joan. You will hear much more about that in the policy roundtable, and I'm glad you'll be at the table.
Thanks, Steve. Kavita.
It's a little bit of maybe a futuristic question, Josh. I come back to the treatment of neutropenia, and I think Dr. Tice, you mentioned that over 50% of the patients in cycle 1, but the effect persisted right through cycles of needing dose reduction. So is it? And so again, I come back to my neurology world where we have loading doses, where we have different doses, and then we stay on a fixed dose for the entirety of the treatment. And so given that dose reduction seems to be a huge part of how you can manage this drug, right, in order to avoid or manage some of these adverse events, could that be a potential way to build in for cost efficiency? Here we are at dose number, this dose, here's the price, but the majority of patients are having to require dose reduction to avoid some of these adverse events. So this is a pricing that's based on what's actually happening. It's a little bit of a diffuse question. Does that make sense, Josh?
Yeah, our model does include the cost savings that would happen with dose reductions. So we have information on dose reductions that we observed in the trial. So if it's different in the real world, obviously that's a question about what would happen in terms of dose reductions in the real world. But the model itself does capture the cost components that would be related to those dose reductions.
And even with those dose reductions taken into account,
yes,
it's not going to fly.
Yeah. On that treatment cost sheet, we had the sort of the starting dose cost, what it would be like, and then the next row down was the as estimated with the dose reductions included. So there was a decrease, but again, not going to create a large difference or a difference in the conclusions we would make.
And the protocol allowed for 2 different dose reductions, which I think Josh incorporated into the model.
Correct. Yeah, there's 2 across the cycles as they come. There's 2 steps of dose reductions that would coincide with those dose reduction estimates.
And I'll go, look it up as well. And that was sort of persisted for a year or
the dose reductions?
Yeah.
Yeah. So what there's a couple of ways that they provide this information. One is just called dose intensity. So it's basically the proportion of the intended dose that patients actually get on average. And so, that we try and maintain that. We have the model is what's called a cohort model. So we have to take averages across that. But yes, those dose reductions after they occurred, they persisted for the remainder of the model.
Thank you.
Andreas, give us your expert opinion on our economic modeling here.
May I ask a question? So my question for Josh would be, if you did a sensitivity or analysis around the cost that you attributed to the adverse effects. So the cost of I was very high, and I'm assuming a lot of that cost came from assigning a cost of $10,000 or what, $8,000 to $10,000 per episode of neutropenia or thrombocytopenia. Yet the number of infections was very low. There's no, from the data from what I can gather from the study, there really wasn't a cost assignable. There wasn't a cost to those episodes. They were simply laboratory assigned adverse events rather. And so I wondered to what degree we recognize that the incidence of adverse events, of low platelet count, low white blood cell count, was certainly significantly higher with the eye drug. But whether that assignment of cost is really fair, or to what degree the assignment of that cost is driving your economic analysis.
Yeah, it's a good point. So the one-way sensitive analysis will look at each one, and it didn't rise to being a major contributor to that. I will note that those are sort of, they're taken individually, so it's not the kind of all the assumptions that you build in there as well. The cost that we have, maybe on the high side. It's difficult to sort of piece all that out because it's unclear exactly what happens with each of those events. Oftentimes there are other blood products or what have you that are used there, or other things. So what we have is essentially kind of the cost of a hospitalization associated with that. Oftentimes the guidelines say, for severe things, hospitalization should be considered, or what have you. So maybe a little on the high side, but again, it didn't, in our sensitivity analysis, it didn't rise to being something that was a major driver.
Okay. I will say, just context, 36% of patients required growth factors, and they required a median of 3 doses, out to 20 plus doses for some patients.
Well, I want to thank CTAF, my CTAF fellow panelists, for their incredible analysis and questioning of the economic models. And Josh, you did a great job on and helping elucidate it. And I appreciate Dan and Jeff's comments also. So thank you very much, Josh.